I'm Catherine Santoro, Director of Programming at the National Institute for Healthcare Management Foundation, and on behalf of NIHCM, welcome to our webinar today. Half of adults in the U.S. have at least one chronic disease, and they account for 86% of our nation's health spending. Yet, many chronic diseases may be preventable by reducing social risk factors. Today, we're pleased to have a prestigious panel of experts with us to explore strategies to eliminate the obstacles to healthy living. Before we hear from them, I want to quickly thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM team who helped to convene this event today, including Kate Ellis, Carolyn Myers, and Kirsten Wade. You can find biographical information for all of our speakers, along with today's agenda and copies of their slides on our website. We also invite you to live tweet during the webinar today using the hashtag #HealthyLiving. I am now pleased to introduce our first speaker, Dr. Kenneth Thorpe, the Robert W. Woodruff Professor and Chair, Department of Health Policy and Management at the Rowland School of Public Health at Emory University. Dr. Thorpe is also the chairman of the Partnership to Fight Chronic Disease, and he's one of the nation's leading experts on effective solutions and policy changes to fight chronic disease. And we're so grateful that he's able to join us today. Dr. Thorpe?
Well, thanks, and thanks for the invite, and thanks for all of you out there who's given up some of their afternoon. I'm going to go ahead and provide a broad overview and some context for the role that chronic disease plays in our healthcare system, in our healthcare economy. Talk a little bit about some avenues of potential solutions to this issue. And then I know as we go through the other speakers, there'll be more specific community-based types of approaches that are increasingly becoming more common. So we'll just go then to the first slide to provide some context here. Chronic disease, I think it's really underplayed as the key driver of rising healthcare spending. In 1987, it only accounted for about 2/3 of national healthcare spending. Well, today it's 86%. So you can see we've had a dramatic rise. 7 out of the top 10 causes of death are linked to chronic diseases such as heart disease, cancer, diabetes. Over time, what we've seen is a rapid growth in the number of patients with multiple chronic conditions. So today, nearly 70% of spending is linked to patients with 3 or more chronic healthcare conditions. And over 1/3 is linked to patients that have 5 or more. This is particularly problematic in Medicare, as 70% of Medicare spending is linked to these really clinically complicated patients that have 5 or more conditions. As we're going to see today on the solution side, however, up to 80% of these chronic healthcare issues could be potentially avoided. We've done some projections at the Partnership to Fight Chronic Disease on the role that chronic illness is going to play in our healthcare economy over the next roughly 15 years or so. Our projections show that between now and 2030, between lost productivity and increasing healthcare costs, chronic disease will account for about $42 trillion worth of economic output. That gives you a sense of about roughly $800 billion a year in lost productivity. The onset of chronic disease is associated with a reduction in family income as workers don't remain in the workforce. They may be less productive at work when they are there. So the productivity piece of this is an important part of the story as well. One of the themes here is what's underlying this growth in chronic disease prevalence. Well, many of these conditions are linked to obesity. Type 2 diabetes, hypertension, hyperlipidemia, pulmonary disease, back problems, depression are all linked to excess weight. And if you look at this chart from the NIHCM, probably the best one to look at is those middle two that are going up. what that shows is that since 1960, we've gone from about 10% obese to about 40% of the population that's obese. So that's a very dramatic rate of increase over a relatively short period of time. If you go to the next slide here, what's striking about this, and you can see it in the CDC state-by-state charts as well, is that the prevalence of diabetes is really following the same trends. So one of the key drivers of this persistent growth in diabetes and other related chronic conditions is the ongoing increases in obesity rates. And I think it's really illustrative to go back and look at some of those state-by-state CDC charts from the 60s and 70s and 80s that looks at obesity prevalence and chronic disease prevalence state by state. One of the things that's important here, I think, in thinking about our strategy for how to control healthcare costs is that healthcare spendings and health issues are not solely within the context of our medical care system. So if you look at this chart that Mike McGinnis and others have done over time, about 40% of the underlying causes of early mortality and morbidity is linked to behavioral issues. About 10% is linked to shortfalls in medical care. So it's not that medical care is unimportant, it's just that these other social determinants of genetics and social circumstance, environment, and behavior changes have a much bigger impact on health outcomes. I think this is kind of an interesting slide. We've done work for the last 15 years looking at the role that the growth in the prevalence of chronic disease versus the growth in how much we spend to treat a chronically ill patient plays in driving up healthcare costs. And given the way that Medicare has largely regulated rates, virtually all the increase in Medicare spending is due to rising rates of chronic disease prevalence. So in the most recent period we looked at, over 95% of it was linked to growing chronic disease prevalence. So part of the solution here on the Medicare spending issue is not unit prices or regulating Medicare budget by silos of spending. It really is got to look at what's driving this long-term growth in the program. To give you just some ideas of some of the growth areas, this is all adults. Diabetes, over the last 20 years, prevalence has doubled. We're seeing substantial increases in diagnosed mental disorders, largely depression and anxiety disorders, arthritis, back problems. All of these are increasing at fairly rapid rates. In the Medicare program, obviously the bars are higher. 22% roughly of Medicare beneficiaries have diabetes. Almost the same percent have a mental disorder. Large numbers have arthritis, back problems. And what you see is that these bundles of chronic diseases within the Medicare population, that these follow very closely, so that a patient with diabetes also has likely to have hypertension, hyperlipidemia, a behavioral problem, back problems, pulmonary disease, and so on. One of the emerging trends that we've seen, certainly on the Hill, in terms of the role that opioids and heroin are playing, and there's a lot of good legislative discussion going on right now. If you look at this table, this is looking at age-adjusted all-cause mortality rates since the 1990s, and globally they continue to go down, except in the United States. Really starting around 1998, among middle-aged white males, the mortality rates are trending up. That's the red line at the top. And it's largely due to increased use of opioids and heroin overdose. So again, that's part of our, got to be part of our discussion in terms of broad solutions here on how do we deal with costs and how do we deal with improving healthcare outcomes. So the prevention framework that we spend a lot of time at the partnership focusing on, that we think is a real pillar of healthcare reform, is really these three areas that broadly speaking, healthcare reform should include efforts to deter the rise in disease incidence and prevalence. We've got to deal with these long-term issues if we're going to get costs and improved health outcomes under control. Improved disease detection. We know that earlier detection of a lot of different conditions provides us more clinical options and it provides a opportunity for better outcomes. We've done a little bit better there, but really, even for things like diabetes, there's still over a quarter of diabetics are undiagnosed and untreated. And the last one, which I think is one that doesn't get as much attention, particularly in fee-for-service Medicare, is that we need to find ways to improve how we coordinate and provide sort of patient-centered healthcare services using teams of care. There's a lot of great state examples of states that have done this. I've done a lot of work in Vermont on this, who've done just an outstanding job of developing community health teams and integrating programs like the support and services at home. That is a potential model that fee-for-service Medicare could really look at to provide really needed care coordination in that population that really needs it. When we evaluate sort of interventions in this framework, the interventions can only succeed if prevention affects people's behavior, because underlying virtually everything we're talking about here are behavior changes that are needed. That the behavior affects health, and that changes in health affect spending, or life expectancy, morbidity, and quality of life. I've done some work looking at community-based determinants of health. I won't go into it in a lot of detail because our speakers to follow are going to dig into this. But if you look at community-based determinants of health, they do include these health behaviors, some demographics, transportation, economics, spending on education, environmental quality, and we've seen that in a growing number of studies linking social service spending per capita on the impact it has on healthcare costs and healthcare outcomes. So again, our lens continues to broaden in terms of the policy options we have to try to address this issue of rising chronic disease prevalence. The piece I did in population health management looked at approximately 470 communities and looked at these outcome variables, percent obese, essentially a variety of indicators of physical and mental health, age-adjusted mortality rates, cancer mortality rates, chronic disease prevalence rates. And the goal was to look at variations across communities and how some of those environmental factors I showed in the previous slide affected these healthcare outcomes. And for the most part, they had very strong effects. The interventions that are in place now, as part of the partnership, one of our members was the YMCA of the USA. We worked very closely with them to get the diabetes prevention program as a covered benefit in Medicare. We've seen for 20 or 30 years the fact that it works. It reduces the incidence of diabetes. It reduces the incidence of hypertension. It saves money. It improves healthcare outcomes. And what's exciting to me was that in April of this year, it's now a Medicare covered benefit, which means that the Medicare Advantage plans also provide it. So that provides an opportunity, I think, to leverage its impact into the commercial sector as well. Also, periodically under discussion, saying that potentially continue to increase excise taxes on tobacco. The federal tax is roughly $1 a pack. We know that if you increase it by, let's say, 1%, that it reduces smoking rates by about 3%. So these are two examples of behavioral tools that are currently in place. Just a summary of that study that I told you about, and this is very very high level is that we found that increase in education investment was associated with improved mental health outcomes and general health outcomes. Environmental issues in terms of ozone and particulate levels were also associated with lower rates of cancer and age-adjusted mortality rates. Social service spending on parks and recreation, public welfare spending is also associated with reduced rates of chronic disease prevalence, in particular asthma, and improved physical health. So I think I have a link there to that study for those people who are interested in those results. So that's the broad overview here. I think that the main message is that any effort to me of really doing comprehensive health reform has got to address the issue of rising rates of chronic disease and really using a broad toolkit of potential interventions to deal with it. Behavioral interventions, financial interventions, increasingly social service interventions. We're seeing some exciting things, I think, happening at CMS, giving Medicare Advantage plans more flexibility in how they use their rebates to tailor healthcare plans for frail elderly patients that integrates housing, social service spending with a more traditional care coordination and prevention. So I think there's a lot of interesting experiments going on that we can learn from, but I think that what we're increasingly seeing is that we're not going to solve this problem solely within the medical care system itself. That increasing co-pays, increasing the deductibles really doesn't address any of these underlying trends that I've been talking about. It's the foundation of it really has to deal with slowing the progression of obesity and slowing the growth in chronic disease and doing a better job of engaging patients that have multiple conditions to keep them healthy and keep them out of the hospital. And with that, I'll go ahead and stop and turn it over to the next speaker.
Thank you so much, Dr. Thorpe, for that presentation and for your leadership on this issue and sort of your recommendations and thoughts on how we can address chronic disease and hopefully address the spending associated with it. Our next speaker is Katie Ives, a Senior Program Officer at the BlueCross and BlueShield of North Carolina Foundation. She joins us today to share their collaborative efforts to support upstream and community-centered approaches to improving health, and we're so glad that she's with us today. Katie?
Thanks very much, and I will have you advance my slides for me as we go along, so I'll let you know. I think this is a good grounding, certainly, and I like this language that Dr. Thorpe used around community-based determinants of health. I think that's the approach that we're grounding our work in, the understanding that the social risk factors are sort of undergirded by systems that increase or decrease opportunity to be healthy at the population level. And so our work truly happens at the population level versus the individual level. And this is but one approach. We call it community-centered health, of how primary care or healthcare generally engages to work with and in many senses be led by community to increase opportunity for good health for all. So now I'm going to move on to the slide number 2. So a little bit about us before I start. The BlueCross BlueShield Foundation was established in 2000. We've made about 1,000 grants totaling $131 million, and we historically funded in 3 core areas. I say that because it becomes relevant to my points today as I talk a little bit about the impact that funding this work and being on the periphery of it as it has occurred in communities we've funded, the impact that has had on us as a funder in terms of really changing our approach. On the next slide, community-centered health, again, is what we're calling it, and the subject of the webinar today is what's being done to eliminate barriers to being healthy. Our approach in a nutshell has been to ask those individuals who experience disparities or who are familiar with the environmental conditions that lead to inequity to prioritize, and by that I mean to set the agenda for the work of clinical community partnerships to reduce those barriers. And sometimes we talk about it in the language more so of opportunity. We'd say reduce barriers and create greater opportunity to be healthy. We embarked on this in 2014, and in some ways it feels like yesterday. But again, it has been transformational to our approach, so much so that we've reframed our strategy based on learning over the last 4 years. In the next slide, the philosophy of this is sort of the general approach we take. And in some ways, it's better to understand what this is not about. It's not about finding and implementing evidence-based programs, and it's generally not about access to care, although it can certainly have that impact. Related to that, I've sort of previewed, it's also not about individuals, but more so about communities and building partnerships to have that impact at the population level, and therefore about seeking and achieving systems level changes that have that impact at the population level. On the next slide, the core components, this is sort of what we understand as 3 core pieces. Community-centered health as we understand it is not a model. It's really an evolving framework that we understand in new ways on a daily basis sometimes as we learn from our grantees and others doing similar work around the country. And while it has many variations, we do think of these 3 components. So the first is that they're clinical community partnerships in which community members themselves are recognized for wisdom and expertise on the conditions that cause poor health and have leadership roles. And the community involvement goes beyond focus groups or general participation to really having community members contribute to the shared understanding of those conditions and play a key role in identifying priorities for action. And to implement that in primary care, what we see is many practices start by asking different questions, like what are your health goals, what are the barriers or what's in the way to achieving them. Looking again at that individual experience more so than evidence. And that's the beginning of this second piece, which is called clinical shift. And what we mean by that is that healthcare organizations make changes in their own processes or culture to the ways they partner or share data with community to both identify and act on those non-medical barriers to good health. That has impacts at the community level, of course, but what we're also seeing is that it impacts patient experience. It does mean that there are very different activities. And in my opening slide, you saw a physician, and that's Dr. Mulberry of Greensboro, and she recently appeared at the city's Minimum Housing Standards Board. So it really does ask in that clinical shift piece for providers and healthcare organizations to really act differently, in this case as advocates. And in some ways, some of the things it's asking are unnatural for healthcare as it has evolved. And then finally, the key piece is that this is really working at the policy and systems change level with a very broad reach. And we believe that that is what sustains impact over the long term and leads to those long-term improvements. On the next slide, just some really technical elements, crosswalking data being a piece of that. The data piece is something that healthcare has a great deal of data, but it's not always informed by the conditions in the community. So crosswalking clinical and community data is a technical approach that is having an impact in these partnerships. And then again, as I mentioned, acting through advocacy as another approach that particularly healthcare organizations and their community partners can undertake. On the next slide, I just really want to mention that this does fit into sort of an emerging theme that we see in healthcare and in the approach to health across the country. And that's that health is not a product of healthcare in its historical sense. That healthcare can play a substantial role in improving health by shifting the gaze upstream of the immediate health crisis while tending to it. And so it does ask to really think about health differently from that healthcare perspective. On the next slide, the grantees we have now are in 3 communities. I'll talk about each of them. We're in the process of identifying a second cohort of likely 7. But I'll go into each of them in detail on the next slide, starting with Healthier Highland. And you see on the slide some of the work they're doing. This is rooted in a community health center. The health center staff is working closely, though, with city planners. And as a result, they've generated in the last couple of years $2 million in infrastructure investments in the community. So those are a direct result of advocacy by primary care, health center staff, advocacy with the planning department to get more sidewalks, crosswalks, housing, splash park, and public bathrooms in a city park. They're also working, again, through the health center as the hub in increasing community representation in some of the civic processes in town. So they have a goal of getting 5 local residents on city and county advisory boards. This is a key strategy that many of the sites we're working with are using, is getting, again, those people who personally understand the factors that are barriers to health, informing planning, parks, transportation in their localities. And that growing understanding of local data and where inequities exist, using that to influence decision-making really has been one of the keys to impact, because I think we find that everyone wants to do the right thing there, and the data can help us understand what that right thing might be. Many of our partners have engaged community health workers. At this site, they've hired a community health worker who was a former worker in their local cafeteria. And she lives in the community and is supporting them to engage on school food. So she brings an expertise on school food. She brings the relationship she has from walking daily in the community, and as a community health worker brings a unique lens to them, both in terms of systems as well as the individual's patient. They're a pilot site for an enhanced benefit for our SNAP program that brings $40 in fresh fruits and vegetables. And so you can see by that sort of mix of things, they really have a mix of both programs and system strategies that engage residents and can lead to lasting change. On the next slide, we have Collaborative Cottage Grove, and that's in the Greensboro community. Their focus has really been on housing, and rather than being in the health center directly, the grantee there is the Housing Coalition, but they're in deep partnership with both a free clinic and the hospital system. So a focus on both primary care environment and emergency department utilization. Everyone understands that this community was an asthma hotspot. Digging into the data from code enforcement showed that the asthma exacerbations were caused by infestations and water intrusions. And the conditions were so bad that there's a 170-unit apartment complex there, and these are not subsidized units. These are units that people were paying a low rate, but a market rate for, and because they were affordable to them, but they were really having an impact, obviously, on their health. And so this partnership of hospital, primary care, and housing advocates advocated with the owner and led to the sale of the complex to a new owner who's committed to bringing up the standard of housing while keeping rents as low as possible. They've done efficiency upgrades with city dollars that will lower utility costs, and so rents will go up, but they think the overall cost is going to remain about on par with what it was before because of those efficiencies on utilities. And so we see this unique partnership coming together to really improve health through housing condition improvements in the community. They've also worked with community health workers, neighborhood associations. They have strong linkages to university programs where they're acting as a training ground for a variety of health services, professionals in the universities. They're using students using Google Street View to assess housing conditions in the community, that they can look at the conditions of the gutters and the paint and use that data to sort of inform some of their hotspotting work. They have linkages to planning and transportation departments. So again, a really complex partnership, but at the heart of it is healthcare. And ultimately, the hospital system there is changed its approach and its policies around data sharing to make its data more accessible to community partners. And they've also changed their mission statement, not a direct result of this work certainly, but with a much stronger orientation to prevention. And we think that's based on the experience. The last example on the next slide is Mothering Asheville, and that's not as much about chronic disease, but again, a partnership that is working on a disparity. They have Black babies dying at 3 times the rate of white babies in their community. Again, they're using community health workers and doulas, and they've developed a doula program that means new jobs for women in the community, and it's being systematized by integrating referral and workflows into their healthcare system. I bring this one up also because they're using legal aid as a partner, and they've embedded legal aid in the OB practice. That's certainly something that can be done in primary care and the medical legal partnership program, because frequently barriers to health at the individual level can be caused by issues such as housing, interpersonal violence, benefits, securing benefits, and many of those issues have a legal remedy. So legal aid has been a key partner in North Carolina on this work as well. I'll bring us next to our 2.0 work. So we have 4 years of experience that we're building on and lessons building on, and so we're embarking on new relationships with grantees. And in the next slide, sort of covering, we issued an RFP for what we call Community Health 2.0, and we received 170 letters of interest based on that. That is the highest number of submissions we've ever received for a grant cycle. So it is clear that there is appetite for this work, and most of those partnerships had healthcare as an active partner at the table already. These communities, of course, exist on a continuum of readiness and interest and commitment to these and similar approaches. And I'll say this is but one approach to support work that acknowledges and acts on these community drivers of health. And it's not the only one we as an organization use, but we believe that this approach will only grow in sort of the level of interest that is out there, as well as the capacity. And we are committed to supporting that capacity. To that end, on the next slide, I want to emphasize this sort of chart shows the types of non-medical barriers that those 170 applicants expressed to us they wanted to address. And so you see healthcare is on there at some level, but more so, the size of those words and the word cloud point to the how frequently they were mentioned by our applicants. So housing, food, environment, ACEs, trauma, these pieces are all resonating with communities and healthcare and community partnerships that they want to address. And when we're talking about chronic conditions, there are, of course, many non-medical drivers represented here that communities have a desire to work on. In the next section, I will just briefly mention some of our learning that we have embarked on or we have inherited, I guess, in partnership with our grantees. On the first slide here is capacity. So while this work seems sort of natural and logical when it's explained, it's actually really unnatural, we found, for folks to partner in this way. Going back to its most basic, the essentials of partnership is even language. When we say residents to primary care, they think of something very specific. They think of medical residents. When you say residents to community partners, they think of people who live in the community. Likewise, when we say population health, what do we mean exactly? Public health and primary health have very different definitions of some of this terminology and expectations of the work, and community is a whole nother stakeholder to consider their definitions and priorities. So we have supported a great deal of capacity buildings in all the communities we're working in. This means leadership, it means facilitative skill set. In many ways, capacity starts with being able to explain the approach, a community being able to recruit somebody, a new partner, because they can explain the work and the return on investment. There's also technical and adaptive work that needs to occur in terms of that data sharing piece, power dynamics, equity and inclusion come up as very important capacities at the community and institution level. And as I said earlier, this has great relevance to patient experience and to some of the technical skills of healthcare, how docs engage with patients, what team-based care looks like, who's on the team and how the team works together, operations and workflow, certainly patient feedback loops. And finally, I'll say equity again. I think being able to have conversations about race and the effects of racism and other systemic oppression becomes key to progress over time in these communities. And so seeing both oppression and its impact over decades on health becomes very important to being able to address the effects of that through systems. And we're being very intentional about making sure our 2.0 cohort has support to elevate equity and the health impacts of inequities at the beginning of their work. On the next slide, I'll talk briefly about sustainability, which I know is key, and I'm sure some are thinking like, how would we possibly pay for this without private funding? And I will acknowledge that sustainability remains elusive, but we have hope. There are not easy answers, and that's in some ways because the data is siloed in different places and must be looked at and shared in new ways. This also sort of makes the ROI calculation very different than most stakeholders are accustomed to looking at. What is the timeline to ROI? Where are you looking to incur your savings? So addressing neighborhood safety, for example, has implications on health, we think, but also on many other budget lines in our communities and social systems. And so we are really partnering with our grantees to look beyond the usual time horizons to ROI and also the usual payers that we think about when we think about health. And so one of the work that we're asking our grantees to do is to have that conversation locally about the time horizon and where community needs to see savings over time. We are very fortunate at the Blue Cross Blue Shield of North Carolina Foundation to have easy access to brainstorm with payers, both public and commercial, but it is challenging. And the question of scale makes it even harder, I will say, because community-rooted strategies are by definition local, and scaling regionally and statewide certainly presents challenges. Some of the partnerships I talked about are truly working in a few square city blocks in their first couple years. Now they're looking to spread into their cities or their towns. But partnering with payers and others to understand questions about scale and scope as well as ROI is an important part of this work. On the next slide, I'll just lead into this has impacted us, as I mentioned at the beginning, in ways we didn't envision. And that, I think, is proof that acting with intention in new ways can impact strategy at the organizational level on a much broader scale than we even anticipate. And so in detail on the next slide, we have basically had access to care, healthy living, and capacity building as our 3 priority areas for the first 15 years of the foundation. And today we're making changes to our strategy that reflect the learning of our grantees over the last 3 years to really, again, elevate equity as a core component, to prioritize policy and system change, to amplify community voice, and really center some of our funding priorities on these non-medical drivers while acknowledging that health care, people in pain today need greater access to health care. And so certainly maintaining that emphasis, but also shifting our gaze a little bit further, we would say upstream. And in the next slide, briefly, we have named some areas of practice that are more consistent with these community-based determinants of health and social determinants of health. And that is, again, consistent with our learning over time. And that concludes my remarks. I can pause here for questions or take them at the end.
Thank you so much, Katie. We'll save all the questions until the end, but thank you for sharing this really important work, a lot of food for thought, and hopefully we can get into it a bit more in the Q&A. We'll turn next to hear from Becky Wampler, Director of Healthcare Sustainability at Wellmark, BlueCross, and BlueShield. Wellmark is really leading the way in their states and community health improvement initiatives, and we're so pleased to have Becky with us today to share a little bit more about their work in Iowa and South Dakota. Becky?
Thank you, Catherine. And I'm stunned at all the great information that we're hearing, and some of mine might be a repeat of some of what Dr. Thorpe shared, so just kind of bear with me if you will. I want to give you a little bit of a background of who Wellmark BlueCross BlueShield is. We're the BlueCross and BlueShield plans in Iowa and South Dakota. And it's important for you to know that we're a mutual insurance company and we're owned by our customers. So this business model is really the basis for the decisions that we make here at Wellmark, and that may help you understand why we're doing what we're doing. So let's go to my next slide. There we go. I'm providing this to you because we're very proud of the fact that our administrative costs are extremely low. Just under 11 cents is used of every premium dollar that we take in to pay for administrative costs. Almost 86 cents of every dollar goes out to pay for healthcare services. And even though we're quite lean from an administrative cost perspective, our board said it's not enough to be administratively lean. We have to figure out how to pay out less dollars overall, or to decrease the overall trend and what's happening with spend. So we looked for efficiencies internal to Wellmark. We looked for efficiencies internal to the whole healthcare system, but we quickly realized that we needed to improve the overall health and well-being of Iowans and South Dakotans in order to reduce healthcare spend. And by now you've probably all heard that your zip code could impact your health more than your genetic code. And we have built a community-based approach to assist citizens in making small changes in their community to improve overall well-being. And to help kind of understand this in a succinct and easy way, we have a short video that explains our Healthy Hometown initiative. So I'm going to play that now and then pick back up here in just a second.
Getting and staying healthy. It can be a challenge, can't it? Between work, school, and other commitments, some days there just aren't enough hours. But have you ever noticed how your surroundings affect your activity level? Just think about your normal day. Is processed food easier to fit into your hectic schedule than a healthy meal? Do you drive to the store rather than walk? How often are you on your phone or tablet? Our day-to-day activities and where we live impact our health. In fact, your zip code may impact your health more than your genetic code. Americans are experiencing more chronic health issues and are more overweight than ever before. 30 years ago, obese adults made up less than 15% of the population. Today, 2 out of 3 adults are overweight or obese. So why do our waistbands continue to get bigger? Well, we consume what's convenient. Items like soda and potato chips are in every convenience store, vending machine, and checkout lane, and fruits and veggies are scarce. More than 75% of kids don't eat green vegetables daily. Americans consume 600 more calories per day than they did in 1970. That's equivalent to an extra lunch. We also eat 30% more added sugar, which is in part due to increased portion sizes. And since 1960, our plate sizes have gotten 36% bigger. In addition to our changing eating habits, we move less. Transportation systems are designed for cars instead of people, resulting in communities' reduced walkability. U.S. adults walk less than 5,000 steps a day, and the number of kids who walk to school declined from 48% in 1969 to 16% in 2011. Even the social connections we make are often virtual rather than face-to-face. Adults spend more than 10 hours a day on screen time, and kids spend more than 6 hours a day, which also leads to decreased physical activity. But there's a solution to these problems, and they start in our hometowns. A community can't change habits, but it can be a guide to better ones. Small changes like creating biking and walking paths and establishing community gardens are just a couple ways to reduce these issues, and Wellmark BlueCross BlueShield wants to help. When citizens band together to make healthier choices easier, the results are enormous. Learn how you can help make the future healthier by visiting wellmark.com/healthyhometown. There you can take a self-assessment or get expert consultation on ways to enhance the well-being of your community, all at no cost. What are you waiting for? Visit wellmark.com/healthyhometown.
going to give you a little bit of background as to why we're going down this path. This slide shows obesity trends in the past 30 years, and Dr. Thorpe spent a little bit of time on this as well. But in Iowa and in South Dakota in the last 30 years, our obesity rate has doubled. It's gone from 15% to 30%. And in fact, we have 2/3 of Iowans and South Dakotans who are either overweight or obese. And this is really of great concern because we know that obesity is a driver of more than 30 chronic conditions, and some experts even say maybe even up to 50. So we took a look at our claims data, and we know that that obesity is a significant driver of costs. Individuals with 1 to 3 chronic conditions account for 58% of the claim dollars that we pay out. And I heard Dr. Thorpe talk about 86% when you consider all chronic conditions. If this goes unabated, it's estimated that by 2030, in our 2 states of Iowa and South Dakota, 1 in 8 of us will be diabetic, 1 in 4 will have hypertension, and 1 in 4 will have heart disease. And when you think about the cost, you can't just add these costs up and say, if I have all 3, it's going to be $65,000. You really have to double or triple it because it exponentiates the more conditions that you have. So the cost is significant. And Dr. Thorpe also talked about the fact that we have the ability to impact a large percentage of those factors that influence our overall health. So while I've painted a bleak picture, there really is some hope. And that's why we created Healthy Hometown. It's designed to help community leaders implement evidence-based tactics that nudge individuals into making healthy choices. And again, I want to say evidence-based tactics that are in the public domain. We've made these resources available to any community in Iowa and South Dakota at no charge. And I know in the video it talked about how you could take a self-assessment or get expert consultation. That expert consultation is in the field. We come to your community and we work with communities who want to engage in this work. And we've organized Healthy Hometown into 3 work streams: eat well, move more, and feel better. That's really easy for communities to understand. And let's look at a few examples of what those things might be. Say a community wanted to work on eating better, that they wanted to work on nutrition in their community. One tactic might be to implement policies to have healthier items available in vending machines, whether it's at work sites or whether it's at ball fields or whatever. You could have a vending machine that looks like this, where it's hard to make a healthy choice, or you could have a vending machine that looks something more like this, where there are several healthy choices available to you. Perhaps the community would like to work on moving more and getting more physical activity and wanting to know what they can do to make their town more appealing for active transportation, walking, biking, etc. Well, let's look at an example. This picture could be any small town in Iowa, South Dakota, or really the nation. And you look at this picture, and it's really not that appealing. It's not appealing to engage in active transportation. I don't even know if it would be safe because it's hard for me to tell where I can cross the street. It's hard for me to know where I should be riding my bike. It's even somewhat difficult for cars to know where to drive. But if this community had a complete streets policy and applied that to that same location, it could look something like this, where it could invite activity and active transportation. So the road width here has not changed, but we've added a bike lane, we've put in a center turn lane, we've demarked the pedestrian crosswalks, and we've also put in bump outs so there's less traffic for the individual to walk across, and that just makes it more inviting and safe to engage in active transportation. And then from a feel better perspective, volunteerism, we all know that volunteerism helps people with their own physical and mental and emotional well-being and having improved social connectedness. The other things that we put in the feel better category are things like tobacco policies, whether or not there are tobacco-free parks, tobacco-free apartment buildings, and things of that nature. We have identified more than 100 evidence-based interventions from entities in the public domain, from places such as the CDC, Robert Woods Johnson Foundation, the Urban Land Institute. and others. Those are just some examples. And we have categorized those into the 3 categories I just went through, but then also where a community could do this work. They could do it at a community level, in their healthcare systems, in their schools, at work sites, etc. So there's a lot of opportunity for a community in whatever they wanted to participate in. And we have found that the community leaders that are really forward-thinking, they realize that a healthy hometown is really good and vital to their local economy because it makes sure that they have a strong workforce, and it just makes their community more attractive to industry who are looking to relocate. So we've gotten a lot of buy-in from business leaders who want to do the work for their communities. I'm going to share with you now just 3 slides. I'm going to go through them quickly because they will actually be posted later after the webinar of what some communities have done. So Cedar Rapids is one of the larger cities in Iowa. They've done a lot of work around community gardens and donating produce. They have put in free shuttles that allow people to get to healthy food options and to farmers markets, and they have a complete streets policy. And they've done a lot of conversions on their one-way streets, turning them to 2-way and putting in bike lanes. Another town is Mason City, which is a mid-sized town in Iowa. They too have done a lot around community gardens and donating of produce. They've also done a lot with bike lanes and activity from that perspective, and placemaking, so a lot of sculptures, encouraging people to be active in their transportation options. And then finally, Sioux City, another mid-sized town, they did a lot with walking school buses, so getting children to walk to school. They have a community garden at their daycare, and they've done a lot of trail expansions. So again, these are just some examples of what communities can really do. And in most cases, there is not a lot of cost to these solutions. And then finally, just a slide to show you our breadth. We are actually, this slide says that we're in 32 communities. I need to update this. We're actually working in about 40 communities now across Iowa and South Dakota. And this is a solution or an approach that a community can choose what works for them. They can choose, like I said, to either eat well, move more, feel better, and bite off what they can chew and get little successes under their belt, and then get kind of the steam built up to take on the next project. So that's what the Healthy Hometown Project is all about, and I'll be happy to take questions after the last presenter. Thanks, Catherine.
Thank you, Becky, so much for sharing that approach. And we do apologize. A couple of questions came in that if folks were having issues viewing the webinar, the video that you played, but we will work with you to make that available
Sure.
to people so they can check it out. At this time, I'd like to introduce our last speaker to delve more into efforts to reduce social risk factors. I'm pleased to introduce Carol Robbins, who serves as the Manager of Social Work at Arkansas BlueCross BlueShield, and she's joining us today to share their innovative efforts to engage social workers as partners in addressing some of the social determinants of health.
Thank you, Catherine. I'm so excited to be here and to be in amongst this wonderful group of speakers. And I think, what occurred to me is that we're all doing something in our communities or within our jobs or within our volunteer organizations to address, what we now know are the social determinants of health that are really impacting access as well as just healthcare in general. So what I wanted to do today is I just want to talk to you a little bit about something that we're doing here in Arkansas BlueCross and BlueShield. Social work was not really on the scene in Arkansas BlueCross until about 2012. And so I think in 2012 we got our first social worker. She was added to the case management department for the Wellmark line of business, and she was, as you can imagine, quickly inundated. Then I think she was replaced a couple of times. Then in 2014 we added With the new Medicaid exchange program, we added the 2 social workers that were community-based to work specifically with a community-based case management program in order to reach that population. And then now we advance to the fact that we do have a separate department. We are within clinical services and population health. And we are, our goal is to make social work available to all lines of business. I'm happy to say that we have most lines of business covered at least on a consult basis here in 2018. This department has a manager, a supervisor, and then we have a total of 13 social workers. And then we also are taking on an MSW intern, trying to get a great team that not only will bond with other teams within our enterprise, but then also out in the community as well. We have both telephonic as well as face-to-face interactions with our members. And again, I wanted to say that we've officially joined the fight. I think for the longest time, we have been working on a consult basis, usually from having an RN case manager, a nurse navigator, or a gap nurse that would identify someone. And typically what we do, we get a consult, we assess for social issues and their impact. We are sometimes able to educate members on any resources that are out there. But more importantly, we assist our members in trying to navigate their own community, and then also advocate for new resources, because I think we're all talking about that increased needs really prompt us all to come up with new resources or to identify new resources so that our members can have a better health outcome. We also explain their own benefits, and we tell them how to use them. When we certainly took on the Medicaid exchange program, we all know that now as Arkansas Works. We've done a lot as far as with education of keeping appointments with your PCP, when to acknowledge, the need for a specialist, utilizing, appropriate areas of care such as ER, urgent clinics, as well as PCP visits and, things like that. So that's typically what we have been doing just on a consult basis. And this slide is one that I wanted to share just to kind of let you know what began to occur to us, and that was based on the 2017 social work consults that we track. You can see that, in most cases, medical expenses and household expenses, in other words, financial assistance, was, certainly one of the major or two of the major needs, followed by, certainly food insecurity is a big one, and, of course, public benefits, accessing Social Security disability, SSI, knowing when and how to apply for that, knowing what the process is, what the wait time is, what you're supposed to do in the meantime, and then certainly transportation, was an issue. Again, these were based on social work consults that we were getting, and because we are nationwide as well as we have several national accounts as well as state level accounts, this is kind of all blended together. So then we began to look closer to home. And so what we saw really quickly, and what's been verified in several presentations, not just today, but in many that are topics of discussion now, Arkansas ranks #1 in food insecurity, and that's just a horrible thing to us. You just don't think about it. You don't think about our kids being hungry, but yet there are several efforts in the community that we do things like cereal drives in the summertime to provide food banks with cereal and cereal bars and certainly funds for that. So that we thought, well, even on an enterprise level, how in the world can we help with that? One of the things that I will just let you know about but not really get into is just as an enterprise, we have set a goal of packing over 700,000 meals this year, and we are well on our way. We have 8 regional offices around the state with staffs, and of course each office is encouraged to get involved in their communities, to help out in their communities, and to be a source of resource for their communities. And so I'm happy to report that over 460,000 meals have been packed so far by employees and volunteers with Arkansas Blue Cross around the state of Arkansas. So certainly there's more to do, and I think probably an overall goal is really over more over 1 million meals. But like I said, I think it certainly is a joint effort here with our employees that are out in their own communities, and certainly it's an honorable thing to be able to help your own community. The other thing we know as far as obstacles to care, and we've kind of identified, and I think somebody else had touched on it, and that is the mood disorders, substance abuse, and unrelated chronic illnesses, untreated, especially diabetes, are leading diagnosis for ER visits. And so that was something that was becoming obvious, and I think it appears to be that so in several lines of business that not only we work with, but it seems that way around the country, is that there are lots of overuse of the ER, and a lot of those reasons that they're there have nothing to do with just an illness or an injury. It has more to do with a chronic illness or behavioral health diagnoses. And of course, another thing on food insecurity is it's the most significant social determinant of health in the U.S. Having to choose between food or health care costs is certainly something that we probably, I know we have run across as far as with our members, and it's difficult to get those answers, sometimes from your patient. But when you do, like I said, there are several resources that we can offer as a social worker, but then also as a social work department, we are constantly looking for more sustainable resources. I believe Katie or Becky had mentioned about, that's certainly an important area to be concerned about. One of the, in particular, I really want to tell you about is we have looked at the Central Arkansas community, our big base of Arkansas Blue Cross is located here in Little Rock, and in this central area there are 3 major healthcare systems, and there are an incredible amount of PCP offices and clinics and wellness centers and things like that are supplying health care here in this area. We worked with the ambulance service that provides emergency care here with their ambulance service and then their paramedicine service. So in 11 of 2017, in November, we joined the case management or care management group here within the Blue Cross area, and also we had medical directors involved. We had other people from Blue Cross who were interested, project management obviously, and we met with our local ambulance service that's called MEMS, and that stands for Metropolitan Emergency Medical Services. They have a coverage area of almost 194,000 people in Central Arkansas with, as I said, the 3 major healthcare systems. So what we wanted to do was to sit down with them and talk with them about something that they had come up with, kind of based on some things that had been happening in Colorado and even in northern Arkansas had been talked about, and that was a paramedicine program. So we met in November, began to talk about what they could do for us, what we could do for them, and we wanted to target our Medicaid exchange program, as I said, known as Arkansas Works. And a lot of times, with this population, they have government phones, they are very transient, they are sometimes living in shelters, have P.O. boxes for addresses, and so a large part of our problem in trying to provide even case management or social work services to these folks is to find them. And also the fact that they have an unusually large number of ER visits a lot of times for various reasons. So certainly MIMS had also had that type of problem. They had looked at their ambulance usage and, based with the fact that there is a lack of transportation, and of course public transportation has a limited number of hours. So you have a lot of the Arkansas Works members who would go to the ER for their medical care, not necessarily always appropriate. So we partnered with MIMS, as we call them, to provide this paramedicine program to target our members, and they cover about, I believe it's 4 counties and maybe parts of a fifth. And we certainly, went to address the targeted area or the targeted members in the Arkansas Works membership that overused the ER, so they had a huge number of ER visits and even possibly inpatient visits. So we looked at that category. We began to identify those patients, and then we began to refer them to the MIMS company, and we began to meet with them, one, to help identify obstacles that were in the way of, them getting adequate care, trying to determine what their needs were as far as looking, why are they going to the ER? And then, how else could we help? Was there a PCP access problem? Was it transportation? Was it food insecurity? And so with that, our agreement was that the paramedics would not only help find these members, but then make a first visit, announce our partnership, and then, try to go and see them in the home and do an initial assessment. Within that assessment, it was a medical assessment as well as a home safety assessment. And, a lot of times these same people were people that the ambulance had also identified as misusing or overusing their ambulance services. So they performed the home assessments. Like I said, they did a very thorough job, wonderful information, and certainly provided corrected contact information. And then as we had weekly meetings, they would make a referral back to the case management department that covered for the exchange, for the Arkansas Works, and also the social work team. And basically what we wanted to do at that point is we set up a team of an RN case manager and a master's level social worker, and we wanted them to go above and beyond what we had generally set out. We really wanted more hands-on. We wanted them to go, above and beyond as far as accessing services, making phone calls for them, finding food if that's what it was, or, just basically trying to figure out, what's bringing you to the ER and, what's not being met, what kind of questions you still have. So we started doing that. We set out the goals of the program. We called it a pilot of a pilot because at this point we didn't know what outcomes to expect. But we knew that we would start small because we didn't want to overwhelm our current system, and we were using staff that obviously was also assigned to the rest of the Arkansas population, Arkansas Exchange or Works population. So we certainly, wanted to start small and to reevaluate. But these on this slide are 6 of the goals that we really had in mind when we started this program. And that was just to define the population. Certainly not being able to find them, as we all know, when we're dealing sometimes with people, they prefer a homeless status, and that may work for them until they get sick. They may have substance abuse problems, but then after a while, it then develops into a chronic illness with liver disease or something like that. So number 2 was to define the social needs that impact the health outcomes and healthcare utilization. And again, that goes without saying. We've talked about that already today. And to define the resources needed. This population as a whole is very fluid. This population is very transient. Again, communication is usually by a government cell phone. Did we need to text? Did we need to, work on transportation? Did we need to partner with somebody else? But to really get down to the refined needs and see how that would benefit, and then to look at the return on investment. So certainly that would be something that we could then bring to our leadership, who were very receptive, to any sort of ideas that we may have. We also wanted to increase the case management and social work team engagement of the target exchange population. We wanted to have them, again, like I said, go above and beyond to be able to, certainly focus on, stepping out of that traditional role of telephonic or, just an initial visit, build on that initial visit, the assessment that we got that the paramedics did for us, and then go from there. We also wanted to increase PCP utilization and to decrease inappropriate use of the ambulance and the ED. So here we go. This, I don't know if you can see, this is the actual chart of what we found, the MIMS participant social work triggers. When we were identifying before, we were looking at things like medical care expenses, in which that's still a large group, but as you can see, mental health and substance abuse was probably even more so. So, even though our consults in 2017 were addressing a lot of these, as you can see, depending on the population, it certainly was shifting a little bit so that, now we're talking, a lot more about behavioral health, and certainly, Arkansas does have its issues, with our mental health services, and so that, would certainly give us something to go back to leadership and, maybe have some ideas on how to partner with someone to provide those services as well. But this was the information that, having MIMS first make that contact and then to have our teams follow up, certainly we're able to address and provide resources for. Our lessons learned, well, we have to utilize appropriate PR and education to introduce the pilot. We had to end up developing a big, large postcard kind of thing to show our joint effort. Certainly this population can be very suspicious of people that are wanting to come in and help, especially, with an ambulance service appearing at the door. So we had to work more on that, and that's still in progress. we needed to refine the assessments for the Medicaid population. A lot of home assessments are actually based on safety for the elderly. And interestingly enough, we've kind of looked at several different assessments from some of the other rehab, home health, and those type of services. And so we're working on a more current assessment that will address safety from gun, illegal drugs, that type of thing in there. And we also are trying to link with additional enterprise efforts. One of the things we do well here at Blue Cross is we try to communicate with each other. We have our divisions, and we try to communicate with each other and make each other aware of what the different programs and what different populations we're trying to access, so that we can, conserve our energies and conserve our people to, work on several things at one time, but not to duplicate those services. And certainly lessons learned to find how to address the social determinants of health at the individual and population levels. We often say that we're a market of one because, we deal with individuals one at a time. And even though we can aggregate data and we can, make determinations of possible areas of need, we still start out, it's one member at a time. Okay, and then one of the things we're all very happy to say is that we do have a very positive outlook here at Arkansas Blue Cross. Social work has been very well respected, has been welcomed, and has been sorely needed. And from our leadership on down, has been very much in demand, either on work teams or in different lines of business that we actually bring on. And so I'm happy to say that I think we found a very comfortable home here at the health plan. Certainly, some of the things I'd like to see done, and I think our whole team would, as well as the backing and support from our leadership, would be to expand the program to be able to address more of these partnerships, to identify some of the different types of social determinants, and then work on solutions. And certainly the next one, partnering with community-based organizations to increase our reach, our effectiveness. We have a lot of rural areas in Arkansas, and certainly we would like to, help mobilize them, because I'm sure we all hear this is, go fix the problem, but don't always, count on adding staff. So I think partnerships, and plus you have your buy-in with those community-based organizations. Also, work with other pilot projects such as Matrix. We've engaged Matrix for some of the same population, as well as some of the Medicare population that we work with in the fight for better health. And then certainly, we look forward to more bonding of social work and case management teams to be able to address the holistic person, clinical as well as social needs. I've often heard Medicare is clinical and Medicaid is social. And certainly, our work with the population known as the Medicaid buyout, the Arkansas Works program, has presented new challenges to our whole enterprise. All right, I want to thank you for having your attention today and giving me an opportunity to really tell you about our programs and be, and know that also we are all kind of joining in this fight together, I believe, from the speakers that you've had before me. So, Catherine, I'll let you have it. Here is my contact information. And also just wanted to reference some of the places I've got this great information. Okay? Thank you.
Great. Thank you so much, Carol. And we'll jump right into the Q&A, and we'll start with 2 follow-up questions for you, and then we'll go into some questions for the other speakers. Could you share your definition of food insecurity? And then the second question is whether you use occupational therapists in your home assessment.
Good point. Well, the MIMS program, let me go with that last question first. The MIMS program is new, 2017, like I said, November. So we really are just now, the reason we called it a pilot of a pilot is because we really wanted to see where we could go with it and what other types of professionals we could pull into it. And so I think, you know, we're now learning. In fact, some of the information I have just received, you know, on this program is kind of giving us that fuel, if you will, in our presentations to back to leadership from our medical directors, to how to be able to pull in other entities, supportive housing, supportive employment. So I can only tell you that I think our plans are big. We also have another ambulance company in northern Arkansas that is very interested in doing the same thing. And so I think it will cause us to really evaluate our outcomes and to really look at predictors, you know, based on a year's worth of data. So yes, I would fully anticipate that we could use occupational assistance as well. We talked about pharmacy, certainly, you know, medication. So I think, you know, the door is just now opening for this.
Great.
Okay.
Did you want to also share your definition for food insecurity?
I'm sorry. Food insecurity.
Okay.
You know, I think a lot of times I've seen this, you know, it's like a buzzword for the 2018, you know, but basically here in Arkansas, our biggest concern is that we have at least, we have a lot of children. I'm not going to quote you stats because I don't have that in front of me, but we have a lot of children here that in the summer, you know, they have no meals, you know, supported outside the home. So, you know, during the school year, they are served a minimum of 2 and then sometimes snacks. So the insecurity is a lot of times for the children of not having adequate food in the home and not having nutritious food to be able to, you know, promote healing, you know, to provide, you know, better, you know, functioning of your body and that type of thing. So food security in this instance is not having enough food to really promote wellness and healthy lifestyles.
Great, thank you.
Mm-hmm.
I'm going to open it up to some questions for the other speakers and start with the question for Dr. Thorpe from someone at the CDC. Do you think that there is a significant role for new approaches to behavior change interventions, such as those described as nudges, meaning subtle changes that help individuals make the healthy choice without mandating or limiting those choices?
Well, I think absolutely, and I think that's those types of you know, strategies for behavior change are a key reason why the diabetes prevention program, I think, has proven to be so effective because it got people to not only do at least 150 minutes of physical activity a week, but built into the educational component were behavioral strategies like nudge that got people to set goals and to help them stay on track to achieve them. So, you know, any sort of innovation along these lines in terms of new research we have and new approaches that help people achieve goals they want to and help people change behavior, I think is kind of a centerpiece of these programs designed to reduce smoking and reduce obesity rates.
Mm-hmm. Are there any, this is a question from someone else, but it's somewhat related, are there any technologies that you think are holding the most promise? You know, I think this is a broad question and it could relate to the nudges, but, you know, also just broadly on chronic disease prevention.
Well, I think, and this is, you know, sort of an ongoing discussion on the implementation of the programs like diabetes prevention program and behavior change programs, is that there are a growing number of internet and remote technology companies that are delivering these interventions in ways that seem to be very effective. They seem to be almost as effective as the approaches that actually have people participating in these classes in person. So I think the remote approaches are important for rural populations and for others that have a hard time actually getting to a larger city that may have a behavior change program. But I've really seen these interventions grow. There's also some interesting work going on with a company called Solera Health that is matching people, physicians and individuals who are eligible for these behavior change programs and certified providers. So there's another example of where technology, I think, is very important in the implementation of these programs.
Great, thank you. This question is for Becky. Could you talk a little bit more about who Wellmark consults with in the community, public health departments, or others?
Sure. Whenever we are working with a community, we want to make sure that they have a core group that can really get work done. And for every community, that may be a little different, but the players that you typically see at the table might be school administrators, business owners, elected officials, mayors or city council people, a city planner or transportation specialist. You might have healthcare providers and public health. And also, you need a huge volunteer effort. So we've seen people who are engaged in Main Street programs and also people who are engaged in hometown pride groups that just really want the best for their community. So we consult with them when they have that core group together that can get work done.
Great. I'm going to direct this question to Katie. With respect to the impact of clinical community interventions on clinical outcomes, many of the current efforts are tailored for those higher on the readiness for change continuum. What approach have you seen or are you taking to engage individuals, communities who are not as engaged in adopting behavioral changes or seeking preventative services so that the clinical interventions have more broad impact?
Yeah, I think that does come down to, this piece of the nudge or making the healthy choice the easy choice is there are certainly communities that have lower capacity because they lack advocacy organizations or some sort of community hub where this work can take place. But we do believe that all communities can begin to take steps to really create environments where people can be healthier. And so that's the core of our focus. And we are working on developing supportive grant making and programs so that communities at any area of the readiness scale can begin to engage. I think the piece is making sure that there are institutions, organizations, or funder commitments that are engaged over the long term so that we don't do more damage in these communities than help by just starting something that we don't intend to finish. And so that is a challenging part of the work.
Sure. This question is for Carol. With the MEMS program, are you seeing any type of results yet in patients accessing and retaining needed resources? And also, could you speak to any results yet in decreasing patient use of the emergency department?
Yes. First off, with the MEMS program, I think, we can already say that just, getting out the awareness to the population that we are interested in why ER is not fixing your problem, and this is giving them a platform to not only, talk to a paramedic about it, but then also when there is, the question about do you want to visit with a social worker, do you want to talk with a case manager, that then it gives them an opportunity to, discuss why they're not getting their needs met. Is there the lack of follow-up? Is there a lack of, getting the medication, that type of thing. And so I think, as we tend to go forward, already MEMS, who had been in this program longer, has some incredible outcomes based on their program to begin with, and there was like a huge reduction in ER, and also a huge reduction in the use of ambulance services, to transport. We had one member, that actually had a scheduled visit with one of our social workers at a public place, and he called an ambulance and had the ambulance bring him to that spot, which happened to be a restaurant, because he couldn't think of any other way to get there. And so fortunately, he now is more aware of public transportation. We had another one who he was never home. He could never be reached by anybody, never by a case manager or anybody else. And so finally, when the MEMS did track him down, we were able to find out that he worked odd hours all the time. And he had a PCP, he could just never get to them because his hours switched from week to week. And so after a few canceled appointments, his physician, his PCP, fired him. So we were able to fix that. So, and like I said, those are things that to you or me, it's very simple, but to someone who's already kind of overwhelmed with life and, suffering maybe from a chronic illness or behavioral health issues, it's quite an ordeal. So I'm happy to report that I really think our outcomes will match or even exceed what MEMS has provided for us so far.
Great, thank you. I'm going to ask one quick question for Dr. Thorpe, and then we'll wrap up. This question has to do with the Medicare Advantage plans. What do you think will be most important for those plans to do to leverage the new flexibilities that they'll have going forward to pay for non-medical services?
Well, I think there's flexibility that's developing in two directions. One is part of the value-based insurance design, which is allowing them to reduce or eliminate cost sharing to get people to actually manage and treat their diabetes and hypertension, to get the regular checkups, to get the extremity exams, where cost sharing puts a roadblock in front of that. But I think that a lot of the issues for frail seniors deals with non-medical interventions. It could be housing, could be transportation issues. It could be dealing with nutritionists. So I think that's a program, as I mentioned in the discussion, the support and services at home that works with community health teams that coordinate care has proven to be an interesting model. So I'm just excited that they're getting that flexibility so that they can do a better job of tailoring interventions to populations of frail elders that can really get healthcare improvements by using both housing, transportation, as well as care coordination and prevention services.
Great. Thank you all so much. I really want to thank our excellent panel of speakers who took time from their busy schedules to be with us today. We are posting a link to the Wellmark video if you missed it. There's also copies of the slides on our website, and we also will be posting an archive of the event in case you missed any of the presentations. Please take a minute to share any feedback from this event with us by completing a brief survey. There's a button on the bottom of your screen. And we also hope you'll sign up for our next webinar where we're going to explore the health impact of loneliness and social isolation, and that will be on October 15th. So thank you all again so much for joining us today.